Hi, I'm Katherine Anderson, reporting for Daily Bulletin. I'm talking with Dr. Wendie Berg from the University of Pittsburgh. Dr. Berg is sharing key learnings from the RSNA 2025 session, adding tomosynthesis to contrast-enhanced mammography reduces false positives. Thank you for joining me today.
My pleasure.
Dr. Berg, your study found that adding tomosynthesis to contrast-enhanced mammography reduced false positives without compromising sensitivity. What does that mean for patients and radiologists in practical terms?
So we're always interested in minimizing false alarms that cause additional stress, anxiety, and cost to patients whenever we have to bring them back for additional testing, often including a biopsy. If we can cut that back without any net cost in terms of detecting cancers, that's a positive, that's a good thing. And that's the nice result that we found, was that in fact, when we added tomosynthesis to the contrast mammogram in a reader study, that the readers were still recalling more findings on contrast mammograms, but many of those could be recognized to be typically benign findings. For example, a lesion in the skin that was enhancing. Contrast mammograms are 2D at this point, and you can't tell where the skin is. And so this was very helpful. Sometimes a bend in a vessel can look like a little enhancing mass, and we could recognize that on the tomosynthesis and then not recall the patient and not cause any stress or additional cost. So those were very helpful things. There were a couple of cases where we found the readers would actually downgrade the case to not recall where they were cancer, and those really just didn't have a correlate on the tomosynthesis. And so word of warning is that you can't downgrade based on the tomosynthesis unless there's a specific good reason, something you see that does explain the contrast finding that we know is benign. We did not include prior mammograms in these patients, so sometimes if, for example, the tomosynthesis were to show a circumscribed mass and we knew from prior tomosynthesis exams that that was stable, then that can also be used to downgrade a lesion. And that's in clinical practice, that happens probably more often than some of these other things. One other situation is when there is a scar. So a lot of these patients had prior breast cancer history and had lumpectomy surgery. There's often skin thickening near the scar. That also can show apparent enhancement, which is actually an artifact from the processing algorithms because the skin is thicker and the manufacturers haven't quite figured out how to solve that. And so it looks like an enhancing finding on the contrast mammogram, but then when you have the tomosynthesis, you can scroll through, you can see, oh, that's exactly where there's just skin scar overlying the breast tissue, and it's nothing to worry about. So those were all helpful. There were also times when a few cancers showed up better because of the tomosynthesis, and I think in those situations it was usually a very small spiculated mass that had not been seen clinically on the tomosynthesis, but knowing there was enhancement, we could identify it. And that helps with reader confidence. It helps with biopsy planning. You could schedule the patient directly for a tomosynthesis biopsy, for example, in that situation. We don't need to re-inject contrast to do the biopsy for those patients. So that can also be beneficial. And obviously we're all comfortable reading tomosynthesis, so having that backdrop of that information that we're so used to seeing, it also just helps with adapting to the interpretation of the new technology, the contrast mammograms as well.
Yeah, and so you also kind of mentioned the additional radiation exposure from combining these imaging techniques.
Right.
In your study, how should clinicians weigh that risk against the potential benefit of fewer unnecessary recalls?
Right. So adding tomosynthesis to contrast mammogram does approximately double the radiation dose to the breast. It's just to the breast, and it's still within accepted limits from the FDA for mammograms. And we know that there's no actual observed harm from that amount of radiation. It's so low, even with the doubling of what you would get with either tomosynthesis or contrast mammogram alone, it's still very much an acceptable amount, and it's not likely to induce cancers, and certainly the benefits far outweigh the harms. One thing I didn't mention is that it is possible to do tomosynthesis both in the same compression as the contrast mammogram, all in one exam. It's also, many of these patients had the tomosynthesis prior to the contrast mammogram, and even when it was done on a separate day, we could almost always still easily correlate any findings between the two exams. And so regardless of how you do it, I would encourage radiologists to always look at least the prior tomosynthesis if they've had it, We also, of course, look at prior MRI. That can be helpful. If there's a stable finding from an MRI 10 years ago, then obviously we're not going to be concerned about biopsying that either. So all in all, this was very helpful to see. One of the things that I was a little surprised by was that there is some variability in reader interpretation of cancers on contrast mammograms, and I think our next step is going to be really to look at that in more detail and develop more training materials, because many cancers are very subtle and were rated by REDS 3 or 4A on the contrast mammogram, and we'd like them to all look like a light bulb and be very easy to see, but the reality is many are very subtle.
Thank you for your time today.
Thank you.
For more information about the study, look for this RSNA 2025 session on demand at rsna.org/meetingcentral. And as always, you can find more radiology news at rsna.org/bulletin.